Thank you, Sri Priya. Hope all of you are engrossed in the sessions, because every day you're getting enough information, new useful information, and hope all of you are gaining knowledge, which you're all eagerly waiting for. Today is another important topic. We have been looking into pain management. What is that that's going to help you to ease the pain and make the patient smile? For that, we have an eminent person, as Sri Priya has mentioned. He is the additional director for PALIM India. And a warm welcome to Dr. Sunil Kumar, MM, who has a very wide range of experience. He's been in palliative care, caring for patients for 20 years. Who else would be the best person to take you through this topic? He has reached this position after obtaining his master's degree from Cardiff, and he's an honorary tutor at Cardiff University too, and he's a national faculty of palliative medicine in India, and also a mentor for the quality improvement project of EQUIP. He heads clinical services, academics, and research of PALIM India. And above all, he has many articles published under his name too. With that, I hand over it to Dr. Sunil Kumar to take us through the session.
Thank you, Madam, for that generous introduction. Am I audible?
Yes.
So let me share the presentation.
Yes, we can see.
Okay. You have already completed NSAIDs and probably the opioids. So today I am going to deal with the opioids for moderate to severe pain, which have the step 3 opioids, and that is available in India. And we know that all the opioids available in Western countries are not available in India. And how the opioids work in our body. And usually many of us will have issues when we use opioids, and there will be many problems coming into our notice. Then we would not know what to do, things like that. So we will concentrate on the practical aspects. And one of the important things that we have to understand is the adverse effect of opioids. So otherwise, we may even produce more harm to the patients. And there are many practices of prescribing opioids, and many of you might be familiar with fentanyl patch, buprenorphine patch, etc. But you may not know of morphine tablet. So it is important for us to understand what is the price involved and whether patient will be able to afford this when you prescribe. So it is our duty to understand the price of different opioids, so that the patient will have symptom control. Otherwise, they may not even buy the patches that you are going to write, and they will continue to come to you with poor symptom control. Okay, with this introduction, I am moving on to the WHO analgesic ladder, which all of you would know. So we know that from the second step onwards, we have opioids, and the second step is used to treat moderate pain, and the opioids which are used are opioids for mild to moderate pain, which includes tramadol, tapentadol, codeine, and dextropropoxil. But in the step 3, we have opioids to treat moderate to severe pain. And can any of you tell me what are the opioids for moderate to severe pain? Please give your answer in the chat box. What are the opioids in the second or third step? Anybody? You can unmute and speak. Audio is not clear. Cyprian?
Sir, it is clear
It is,
for us.
see, the thing is, I felt that little bit volume is low. Maybe, do you want to get your mic a bit closer, Dr. Sunil? Because it was, I was also about to type and then they have typed. The thing is that it's not, like what to say, it's a bit low.
Okay.
That's why I thought maybe have the mic closer if you're using or something like that. Just try, Dr. Sunil, and then we'll see.
Step 3 opioid available in India. So can anybody tell me what are the opioids in the step 3?
Morphine.
Yeah, what are the step 3 opioids? Can you name those? Morphine, fentanyl, yes. Any?
Methadone.
Yeah, methadone. So morphine, fentanyl, and methadone. Those are the step 3 opioids available in India. Okay. So please see this picture of this patient. From this picture, what do you understand? What's his problem? Anybody?
Severe pain.
Severe pain. Yeah, that's right. So he's a patient. He's a 56-year-old man with a carcinoma of the larynx, and he's in severe pain. So this is the pain description. He says he has pain around neck, which is continuous and sharp, and his course 10 by 10. That is worst imaginable pain without any radiation. And he was unable to sleep because of this pain for the last 2 weeks. Sorry?
It was just some disturbance sound, I think, Sunil. If it was something else, please, that person, let them speak.
Sripriya?
Sir, you can continue.
Okay. So this patient was unable to sleep because of pain. And so if you see a patient like this, how are you going to manage? Suppose this patient comes to your clinic or hospital. How do you manage this patient? Anybody?
You can start tramadol and paracetamol combination along with nortriptyline 10 mg at night. Nortriptyline.
Tramadol and paracetamol. Okay. Yeah, Dr. Shika says NSAIDs. Dr. Shreya says jump directly to step 3 as it's severe. Okay. So after about an hour of attending our clinic, you can see the patient, how he is now. What made this smile possible? What is the reason behind that? So it is because, as Dr. Steyer told, the patient has severe pain. He scores 10 by 10. So when the patient has acute severe pain, then we can directly go on to step 3. Patient has severe pain. So step 3 of WHO analgesic ladder is used to treat severe pain. So you can directly go to step 3. So you can give morphine. So this patient within an hour is smiling at us, and it is because of injection morphine. Okay, so in acute severe pain, sometimes if some of you may not have injectable morphine, then oral morphine can be given. But if injectable morphine is there, you can give faster pain. Okay, so which is known as intravenous morphine titration or intravenous morphine trial. So how do you do an intravenous morphine titration if the patient has severe pain? So this is how you have to do the intravenous morphine titration. You need to give injection morphine 1.5 milligram at 10 minutes interval. Okay. So if you give injection morphine to a patient, what is the immediate side effect that you are expecting? What is the immediate side effect?
Respiratory depression.
Sorry?
Sedation.
Sedation. Pruritus, nausea, vomiting, nasal itching, respiratory depression, vomiting. Yeah.
Then the dose is small.
It is actually nausea and vomiting. That's what you can expect by giving 1.5 milligram of morphine. So you have to give an antiemetic, and the usual antiemetic or antiemetic of choice usually is injection metoclopramide 10 milligram IV. So first you have to give injection metoclopramide 10 milligram IV, followed by injection morphine 1.5 milligram at 10 minutes interval. And how long would you continue to give injection morphine? Or otherwise, what is the endpoint of injection morphine titration? So endpoint is either the patient should have satisfactory pain relief or patient should develop sleepiness, whichever be the first. Okay. So some of the patients may not have good pain relief. Instead, they may develop sleepiness. So that's the endpoint for those patients, because all the pains are not opioid responsive pains. So while you give injectable or IV morphine trial, you can make a chart like this, which will give you the time, pulse rate, respiratory rate, blood pressure, what is the pain score of the patient, and is the patient drowsy or not, and what is the dose of injection morphine that you have given. So the pain score and drowsiness will indicate the endpoint of morphine trial. Okay, suppose this patient came to us at 10 a.m. So we record pulse rate, respiratory rate, the blood pressure, and patient says my pain score is 10 by 10. Patient is not drowsy, and then you will give first you will give injection metoclopramide, and then you will give injection morphine 1.5 milligram. Then you will wait for 10 minutes. So at 10 a.m. you will again record the vitals. You will ask the patient, what is your pain score now? Patient says it's 7. And patient is not drowsy, so you will give another 1.5. So you can see this patient at 10:30, when you asked, his pain score is now 1, and the patient is not drowsy. So 1 means the patient has good pain relief, so or satisfactory pain relief. So that's an indication to stop the injectable morphine titration. So you will stop there. So this is how you will do intravenous morphine titration. And injection morphine, the injectable morphine available in Kerala, it contains 15 milligram in 1 ml. And the strength of the ampule may vary from states to state. So we dilute the 1 ml of morphine with 9 ml of normal saline. So total 10 ml contains 15 milligram of morphine, and each 1 ml contains 1.5 milligram. So that's why 1.5 milligram of morphine is given every 10 minutes. So this is not an inpatient procedure. You can actually do it on an outpatient basis. And suppose after the morphine trial, patient wants to go home. So how do you convert this intravenous morphine to oral morphine? So this patient received 4.5 milligram of injectable morphine, IV morphine. So how do you convert this to oral morphine? Anybody? How do you convert injectable morphine? So 4.5 milligram we have given, and how do you convert it to oral morphine? Five milligram. Dr. Bhargav says 5 milligram. 1/10 dose is IV. Dr. Santoshi. Okay. Anybody else who usually use injectable morphine? 30 milligram per oral is 10 milligram IV. Okay. Any more response? Dr. Straya, how do you use it? Dr. Shamla says 3 milligram. Okay. There is no hard and fast rule, but the method which we use is this method. This is an approximate 1:1 ratio is a good starting point. That is initial intravenous morphine dose. Whatever you have given initially as intravenous dose can be given as the first oral dose. So 4.5 milligram means it is not possible to give 4.5 milligram tablet. So you can give 5 milligram. And you can see this is the reference for this. This is a study conducted by our chairman, Dr. Rajagopal, and his colleagues in 2000. That is intravenous morphine for emergency treatment of cancer pain, which was published in Palliative Medicine. And they found out that the 1:1 ratio is a good starting point, and almost all the patients got good pain relief with this ratio. So we know that intravenous morphine is 3 times more potent than oral morphine. That is 30 milligram of oral morphine is equal to 10 milligram of intravenous morphine. But it is not applicable here because you have given morphine, intravenous morphine, 4 or 5 times, and you are converting it to oral. The 3:1 ratio is applicable when you have given intravenous morphine at least for 24 hours. Then only the blood level of intravenous morphine will be stabilized. So when you convert after 24 hours, then only you can apply the ratio of 3:1. But here the patient has received 3 or 4 or 5 doses within an hour, and then you are converting intravenous dose to oral morphine. So 3:1 would not be applicable here. Okay, so that's why 1:1 ratio is used. I hope you understood this. Okay, so you have started the patient on 10 milligram half, that is 5 milligram. So when would you give the morphine, and how frequently? You have to give it 4 hourly. So when the patient, suppose instead of when the patient wakes up, make it 6 a.m. and instead of bedtime, make it 10 p.m. Okay, so 6 a.m., 10 a.m., 2 p.m., 6 p.m. and 10 p.m. So you will give 5 milligram at till 6 p.m. and at 10 p.m. you will give double dose. That is 5 milligram double, it's 10 milligram. And in addition, you will also give SOS dose of morphine. That's the normal dose. You are giving 5 milligram. So SOS dose would be 5 milligram. Suppose a patient is taking 10 milligram 4 hourly, the SOS dose would be 10 milligram. If it is 100 milligram 4 hourly, SOS dose would be 100 milligram. Okay. So why I have written instead of 6 a.m. as when the patient wakes up is that we know that the patients who are in pain will be usually sleeping in the early morning hours because they were unable to sleep at night. probably they will be sleeping. So we need not wake them up to give morphine at 6 a.m. Let them sleep, and when they wakes up, give the first dose. But the next dose would be given at 10 a.m. So likewise, they need not awaken till 10 p.m. If they want to go to bed early, say 8 p.m., 9 p.m., give them the double dose at 8 p.m. or 9 p.m. and let them sleep. Okay. So whenever somebody says it's 10 milligram, half Q for H and SOS, you have to understand that it is given like this: half, 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 one, and half SOS. So many of you may not have injectable morphine, and you have only oral morphine. And in such instances, if the patient is not taking any opioids, including weak opioids, then you can start the patient on 5 milligram of morphine 4 hourly and SOS. If the patient is taking weaker opioids like tramadol, tapentadol, codeine, then stop it and then start the patient on 10 milligram 4 hourly and SOS. Okay. So our patient, Mr. X, we started him on 5 milligram of morphine 4 hourly and SOS dose. And you can see he was relatively pain-free for 2 weeks, but then he needed 4 SOS dose of morphine per day for the last 4 days. So would you do anything with the morphine dose? And how frequently would you give SOS dose of oral morphine? Anybody? Yeah. Sustained release 30 milligram BVD. SOS will be continued. Dr. Anup says 30 plus 20 milligram, 15 milligram. We will divide it for hourly. Yes. Increase the dose. Yes. All of you are correct. So we now know that the patient needs 4 SOS dose. That means the dose which we are giving regularly is not enough for the patient. That's why he is taking more SOS doses. So when would you increase the dose? What is the indication? One of the indication is when the patient is taking 2 or more than 2 PRN dose. PRN is same as SOS dose. Okay. So if the patient is taking more than 2 or more than 2 SOS dose, then you can increase the dose of oral morphine by 30 to 50%. Not every 2 to 3 days, you can increase every 24 hours. Okay. So here you can increase the dose from 5 milligram to up to 10 milligram Q for H. 10 milligram would be 100% increase. So Dr. Anup said this patient is taking 5 milligram Q for H. That means patient is taking 30 milligram and he is taking 4 SOS dose. That means 20 milligram. That is 30 plus 20. That is 50 milligram. So you can either give 7.5 milligram of morphine 4 hourly or 10 milligram of morphine 4 hourly. 10 milligram of morphine 4 hourly would be 60 milligram. 7.5 milligram of morphine 4 hourly would be 45 milligram. Both are acceptable. But this is a general principle. If the patient is taking 2 or more than 2 SOS doses, you can increase the dose by 30 to 50% every 24 hours. So the next question was, how frequently can we give SOS dose of oral morphine? Or what is the minimum interval between 2 doses of morphine? Any answers? Minimum interval, doctors, minimum interval is 1 hour. Okay. Anybody else?
Okay, we are only talking about what should be the minimum interval between two SOSs whenever the patient has failed, Dr. Kamaksh. Yeah. Okay, so for this we have to understand a little bit of pharmacology. So this is the poppy plant or opium plant, and this is legally cultivated only in 3 states of India. Can anybody tell me which are those 3 states? Some of you might be from those states. I'm not sure. So UP, MP, and Rajasthan. These are the 3 states which can legally cultivate opium plant. You can see these are opium fields. The seed-like thing, this one is known as pod, pod, and pod is the most abundant source of morphine. But from any parts of the body you can get morphine, but pod is the most abundant source of opium. You can see farmers are making small cuts on the pod so that the sap which is oozing out, the farmers will collect the sap and dry it in sunlight, and then they will transport it into the government opium and alkaloid factories, and these factories makes morphine powder out of it, and then these factories will send this morphine powder to different pharmaceuticals, and they will make morphine injection morphine tablet capsule out of this powder. Okay. And morphine is absorbed from the upper small intestine, and morphine is water soluble. Okay, so this is important. Morphine is water soluble, so it has a slower onset of action, but because of the same property, it has longer onset, longer duration of action. So that's why morphine acts for 3 to 5 hours, but roughly we say 4 hours. And you should not give morphine sublingually, because it will take long time to absorb from the sublingual route. So it is not advisable to give morphine through sublingual route. And if somebody says they have good pain relief after sublingual administration, it is because they have swallowed it. And buccal and gingival route is also not advisable. So gingival, buccal, and sublingual route are not advisable. And morphine has a bitter taste. This is important when you powder the morphine tablet and administer when they are unable to swallow. So sweeten it with fruit juice or sugar, something, so that the bitter taste can be masked. So what happens to morphine when you swallow it? So it will go into the GI tract, and it is absorbed into the blood vessels of the GI tract, and from this blood vessels they will drain it into portal vein, and from the portal vein it goes to the liver, and where metabolism of morphine takes place, and these metabolites are liberated into the systemic circulation. Okay, so it is gone into the gastrointestinal tract, and from the upper small bowel, the blood vessels of upper small bowel will empty this into the portal vein, and portal vein carries this to liver where metabolism takes place, and then the metabolites are liberated into the systemic circulation, which will give you pain relief. And in addition to metabolism in liver, which is actually the main site of metabolism, minor part also happens in GIT and kidney. And 90% of morphine is converted into metabolites, and mainly this is converted into 2 metabolites known as morphine 3 glucuronide, in short M3G, and morphine 6 glucuronide, which is M6G. So you can see M6G is formed in less quantity, whereas M3G is formed in higher quantities. But the M6G is the active component which will give pain relief. M3G doesn't have much action in our body, or it may sometimes contribute to neurotoxicities. Okay, so M6G is the component which will give you the pain relief. So morphine has to be absorbed from the small intestine, then goes to the liver, and then metabolized in liver, and metabolites are liberated into the systemic circulation, which will give you the pain relief. So it will take some time. Okay, so when you give morphine through oral route, it will take approximately 30 minutes to begin the pain relief. So by the end of 30 minutes, the patient will have some pain relief, but the peak action would be by 1 hour. So it is better to wait for 1 hour before administering the next dose of morphine. So if you administer a patient a dose of 5 milligram at 6 a.m. and patient says, I do not have pain relief by 6:20 a.m., wait for some time and tell the patient that it will take some more time to act. We will wait for another 40 minutes to have good pain. So the minimum time between 2 doses of morphine is 1 hour. So our patient, his morphine was increased to 10 milligram, and he is taking every 4 hourly. But patient says it is very difficult to take it every 4 hours. That's very true, isn't it? Because we know that when we are asked to take maybe amoxicillin 3 times a day for 5 days, how many of us would complete this 5 days, 8 hourly? So this patient is asking whether would it be possible to give it less frequently. What would you do for this patient? Okay, I can see some answers. Dr. Arora and Dr. Shika says sustained release or controlled release. Both are same. Okay. Okay. Yeah. Anybody else? Any other answers? $15 milligram 6 hourly. And Dr. Kamakshi says gradually taper the dose. Okay. So one of the aim of our pain treatment is not solely to reduce pain. It is to make the patient to live actively. So when we give more than the required dose, there is a chance that the patient will become drowsy. Okay. So when we give 15 milligram every 6 hourly, there's a chance that patient may become more drowsy. So what else can be done? So we can give sustained release morphine, which is also known as controlled release morphine. And the duration of action of sustained release morphine is 12 hours. Whereas the immediate release morphine, the duration of action is 4 hours. So here we need to give morphine every 12 hourly, or you have to give only twice a day. So this patient was taking 60 milligram of morphine every day, wasn't it? 10 milligram 4 hourly. That means 60 milligram. So you can give TAM morphine, sustained release 30 milligram BD. But if this patient, there is a chance that this patient can have pain in between. So what would you do for this patient? PRN dose? Yeah, PRN dose we can give. So what would be the PRN dose? Yeah, what is the dose that you are going to give for this patient? So this patient is now taking 60 milligram of morphine, isn't it? So 1/6 of the total dose is given as SOS dose. So 60 by 6, it is 10 milligram. So the SOS dose should be immediate release morphine, not sustained release morphine. So morphine, immediate release, 10 milligram SOS can be given. And what are the preparations of morphine available? So we have aqueous solutions or syrup, tablets as well as capsules, which are immediate release as well as controlled release, and injection. Okay, so these are the 3 preparations available. So we increase or the patient's Mr. X, he is on 10 milligram of morphine every 4 hours for the past 6 months. And then he was brought to the casualty with excessive drowsiness. And on investigation, you find that his total count is elevated, blood urea is 20 milligrams per deciliter, serum creatinine is 5 milligrams per deciliter. So for this patient, would you do anything with morphine dosage? Switch to fentanyl patch. Okay. Reduce the dose by 30%. Okay. TC, that is total count. Okay. Why this patient is drowsy? So there are some differential diagnosis, but with this patient, we will. Okay. So this patient, we have to understand that of morphine. How morphine is excreted from the body? It is excreted by glomerular filtration. So what happens if the patient has a chronic kidney disease or increased serum creatinine? The morphine and its metabolites, it accumulates. So whatever you are giving, it is mostly then there in your blood. It is not excreted from the body. So what happens is the half-life is prolonged. So that's why patient becomes drowsy. Okay. So this is what you have to understand. Morphine is excreted from the body by kidney. So in chronic kidney disease, you have to increase the spacing, and the dosing can be TID, 6 hourly or 12 hourly. So it is not 4 hourly. And instead of 10 milligram, you can make it 5 milligram. Or you can use those opioids which are safe in renal failure. Okay. So so we reduced the dose of this patient to 5 milligram 8 hourly, and he was sent home. And after 2 months, patient was unable to swallow anything, including morphine. Probably patient is near end of life, and patient is at home. So what would you do for this patient now for pain relief? How can we give pain relief? Okay, IV morphine, yes, fentanyl patch or IV morphine. Okay, this patient is at home. So would your hospital allow injectable morphine to send patients home? Depot morphine is not available. buprenorphine or fentanyl patch, injection morphine. So injectable, the problem is, would your hospital allow it to taken by the patient? Is there any other way? Patch is an option, but there are many problems. Yeah, rights tube is an option if the patient was not at the end of life. But if the patient is at the end of life, is it good to put a rights tube? Rectal subcutaneous route. Yeah, subcutaneous route again. You have to give injection, isn't it? So for this, you have to understand what are the routes through which you can administer morphine. So most common route is oral, followed by subcutaneous and intravenous. And morphine can also be administered rectally, then epidural and intrathecal. So for this patient, the patient who is near end of life, or for those patients who are unable to swallow morphine, you can actually administer morphine rectally. And what formulation can be used and how frequently. So whatever you are giving orally, that can be given rectally. Okay. So here patient is taking morphine 5 milligram 8 hourly. So you have to give morphine 5 milligram 8 hourly through rectal route. I told you before, morphine is water soluble. So you can take 5 milligram of morphine, make it a paste by adding 2 drops of water, do a rectal examination, and rub it over the rectal mucosa. The effect will be the same. And even some literature saying that even rectal route is more superior to oral route. Okay. So for this patient, we will use the same preparation, same the duration of action or the administration duration will be the same as that of oral. So now we are moving on to another patient. This is Mrs. K, who is a 55-year-old lady with carcinoma of the colon, who complains of abdominal pain, which is continuous in nature, and she is on 10 milligram of morphine 4 hourly, and she has good pain relief. Okay. So as the patient doesn't want to take it every 4 hourly, she requested the doctor, is there any other way? So the doctor talked about sustained release morphine, but she told if it is some patches available, I would like it more. So the doctor asked them to replace the morphine with 25 microgram fentanyl patch. And next day, the patient comes to you and she tells you that she replaced the fentanyl patch after 5 hours as she has no pain relief. So what would you do for this patient now? She says, I do not have pain relief. What would you do? Okay. Anybody? Increase the dose of morphine till pain relief. Wait as onset of action is slow. Patch take 4 to 6 hours. Increase the dose of fentanyl patch. Okay. So there are many answers, but we have to understand a few important things about the fentanyl patch. So this is the transdermal fentanyl patch. You can see that there is a protective liner on the back of the fentanyl patch, which you will peel off vial application, and there is a drug reservoir, and from this drug reservoir, the fentanyl will be slowly liberated into the subcutaneous tissue where there is more blood capillaries. So fentanyl, it first forms a subcutaneous tissue depot. Okay, so when you apply fentanyl for the first time, fentanyl patch for the first time, it will the fentanyl will be liberated into the subcutaneous tissue and will form a storage in the subcutaneous tissue. And for this storage to occur, it will take about 8 to 12 hours. And once this storage happens, then the fentanyl will be slowly liberated into the systemic circulation. So that means till 8 to 12 hours, the patient may not have pain relief. So what should be done? The patient should be asked to take the previous opioid for about 8 to 12 hours after the application of fentanyl patch for the first time. So this patient need to continue the morphine for first 8 to 12 hours. Then only the patient will have pain relief. So these are the real patient stories, because we see a lot of patients, and this is one of the patient. And it is our responsibility to actually educate the patient about opioids, especially fentanyl patch. And there are many other things which we need to tell the patient. Its duration of action is 3 days. So once you apply fentanyl patch, you need to replace it every 3 days. And patient should not take hot bath or should not go to near the stove, because the temperature it will increase the absorption. And also you should not shave the area. You should not shave the area while you apply the patch, because it will produce micro abrasions, and this will increase the absorption of fentanyl. So these are the few things which you need to tell the patient. So you know that once applied, the fentanyl liberated into the circulation, systemic circulation, will be same. You will not be able to alter the concentration. Suppose you apply 25 microgram patch, that means 25 microgram would be liberated every hourly. So if the patient has an unstable pain, that means patient whose pain suddenly shoots up, then comes down, then again goes up. So for those patients, fentanyl is not suitable. Fentanyl is suitable when you have a patient with stable pain. Okay. So these are the preparations of fentanyl available: injection, transdermal fentanyl patch, and oral transmucosal fentanyl citrate. This OTFC, which was previously available, but I think it is not available now. So it is like a lollipop, and it need to be rubbed on the buccal mucosa, so which will give you instantaneous pain relief. So if the patient has, suppose the patient has pain when they goes to bathroom, so you can rub it over the buccal mucosa. That will give instantaneous pain relief, rather than giving morphine, because morphine will be acting for 4 hours, which can make the patient drowsy. But here it is short acting. And compared to morphine, fentanyl is lipophilic, and it is 100 to 150 times more potent than morphine. So that's why the fentanyl is given in micrograms. And you can see, if you remember this, only one comparison: 60 milligram of oral morphine equivalent per day is equal to 25 microgram per hour fentanyl patch. So if you remember this, then you can actually convert various doses of morphine into fentanyl patch. So 120 milligram of oral morphine would be equivalent to 50 microgram of fentanyl patch. Okay. So this is considering that fentanyl is 100 times more potent than morphine. And suppose this patient has breakthrough pain or pain in between, then you can ask immediate release morphine 10 milligram to be taken, because you have converted 60 milligram of oral morphine to 25 microgram per hour batch. So 60 milligram is take 1/6 of the 60 milligram, which would be 10 milligram. So 10 milligram of immediate release morphine can be given as SOS dose. Okay. So now we are moving on to another situation. This is Mr. P, who is a 70-year-old man with carcinoma of the lung and is complaining of throbbing pain on front of chest, which is continuous in nature, and his post 5/10. He is a non-epileptic and he is on levetiracetam 500 milligram BD. How will you manage his pain? Anybody? Anybody? So what is the pain score? It is 5/10. So which step of WHO analgesic ladder are you going to use for this patient? Anybody please tell me? Okay, second step. So from the second step, which opioid would you select? Yeah, weak opioid. Which one are you going to select? Tramadol. Yes, tramadol. Shika, Kamakshi, Kavya. Oxycodone is not available in India. Tramadol. Yeah. Yeah. So yeah, that's correct. But there are a few points which you have to understand. Yeah, Dr. Arora says tramadol, high doses aggravate seizures. So tramadol has a tendency that it can reduce the seizure threshold. So this patient is already a non-epileptic. So if you give tramadol, there is a chance that you may precipitate a seizure. So it is better to avoid tramadol in patients who are epileptic or patients who has reduced seizure threshold, like brain metastasis, or patients who are on tricyclic antidepressants. So they have a reduced seizure threshold. Okay, so better to avoid tramadol in this patient, even tapentadol, and maybe even low dose morphine would be good for this patient rather than tramadol. Okay, this is another patient. Mrs. P is on tab morphine 50 milligram 4 hourly. She attends your clinic with severe pain. So in your clinic, you have injection pentazocine and oral morphine tablet. How do you manage pain in this patient? Anybody? So which one would you use? Injection pentazocine or oral morphine? Injection pentazocine, which is the brand name is Fortwin. Okay, so Dr. Arora as well as Dr. Anup says morphine. So why not pentazocine? Yeah, Dr. Kamakshi says pentazocine. Okay, so for this, we need to understand again a little bit of pharmacology. So what are opioids? So a medicine to become opioid, it should have two properties. One is that its action is produced by combining with opioid receptors. And another is that its action should be antagonized by naloxone. So these are the two properties for a medicine to become opioid. Okay, so accordingly, there are three opioid receptors, mu, kappa, and delta. And these receptors are there in the entire nervous system, but is mostly concentrated in the central nervous system. And according to the action on the receptor, opioids can be classified into three types: agonist, antagonist and agonist. So what is an agonist? Agonist means when you give an agonist opioid, it will act on opioid receptors to produce the physiological effects. So what are the physiological effects? Pain relief is one, but the other problems like constipation, urinary retention, itching, all those are physiological effects. So agonist is one which will produce the physiological effect. What is an antagonist? Antagonist means it acts opposite to agonist, but antagonists work only in presence of an agonist. So antagonist example is naloxone. So suppose if I give injection naloxone to you, it will not have any action in your body because you are not taking any opioids. So antagonists work only in presence of an agonist. So what is an agonist antagonist? Agonist antagonist means this group of medications. Examples are buprenorphine and pentazocine. On certain receptors, it will act as agonist, whereas on another receptor, it will act as an antagonist. So the effect is combined. So that's why it is called as agonist antagonist. So another thing is that look at this graph. So this is a graph which on the x-axis is the dose of the opioid that you have given, and on the y-axis is the pain. And suppose you are giving an agonist opioid like morphine. Suppose you give 5 milligram of morphine, that will give you some pain relief. But as you increase the dose, it will give corresponding pain relief. So you can see when you give this much dose, the patient would have 100% pain relief. That means as the dose is increased, there would be corresponding pain relief. But what happens in agonist and agonist? You can see up to a point, up to this point, when you increase the dose, the patient will have corresponding pain relief. But after this point, even if you increase the dose, there will not be any corresponding pain relief. Okay, the curve plateaus. So this is known as ceiling effect for analgesia. There is a ceiling up to which you can increase the dose. So agonist and agonist have ceiling effect for analgesia, whereas agonist opioids does not have ceiling effect for analgesia. So let's look at pentazocine. Pentazocine is a agonist at kappa receptor, whereas it is a weak antagonist at mu receptor. Whereas morphine is a mu agonist. So our patient is already taking morphine, and morphine is working as a mu agonist. So suppose you give pentazocine to this patient, what happens? The morphine from the mu agonist will be displaced by the pentazocine, and now mu is occupied by pentazocine. And what is the action of pentazocine on mu? It is a weak antagonist. And now the pain relief could be due to the action of pentazocine on kappa receptors. And the opioids which acts on mu receptors are the potent opioids. So morphine, methadone, fentanyl, all those are mu opioid agonists. Okay. So if you give pentazocine to this patient, what happens is even the patient can have more pain. Okay. So it is not wise to give an agonist antagonist to a patient who is on large dose of agonist opioid. So in this patient, instead of injection pentazocine, you have to take a detailed history, find out whether the patient has missed any scheduled dose of morphine, and give morphine SOS dose. Okay. So now we are moving on to adverse effects of opioids. So what are the adverse effects? We can divide it into two: side effects and toxic effects. So what are the side effects? Can anybody tell me what are the side effects? Side effects of opioids in general? Okay.
Dry mouth, constipation.
Not clear.
nausea, vomiting, constipation.
Nausea, vomiting, constipation. Okay. What are side effects? These are adverse effects with therapeutic doses. Okay. So these are, as you told, constipation, nausea, vomiting, sleepiness, and tiredness. So these are the common side effects. And there are itching, dry mouth, and urinary hesitancy. These are rare side effects. So constipation, it occurs in almost all patients. And as long as the patient is on opioid, there will be constipation. So you have to prescribe a laxative. What type of laxative? A stimulant laxative should be given along with any opioid. So whenever you write opioid, you should also write a stimulant laxative. Otherwise, the patient will be constipated. So the stimulant laxative examples are bisacodyl, sodium picosulfate, and senna. Okay. So there are many types of laxatives available in the market, and patients will be on that. So you have to see the what are the medication the patient is taking, and the powder type laxative. Methyl cellulose, that's the one which is usually prescribed by many doctors. So you have to stop it. Actually, it is bulk forming laxative, which is actually contraindicated in opioid-induced constipation, and you should prescribe stimulant laxative. Nausea and vomiting, it is due to stimulation of chemoreceptor trigger zone. Mainly, there are many other mechanisms, but this is one of the main mechanisms which will induce nausea and vomiting on giving opioids. But compared to constipation, nausea and vomiting occurs only for the first few days after the initiation of opioids. So maybe for a 3 to 5 days, you need to give an antiemetic, which mainly act on CTZ, and haloperidol and metoclopramide are the two medication which usually we can use. Sleepiness and tiredness, again, it occurs in almost 1/3 of the patient, but it is also self-limiting within a few days, maybe after a week. So we need not do anything for sleepiness and tiredness. And what are the toxic effects? So these are the adverse effects when the administered dose is higher than the required for pain relief, or when the patient's pain has poor response to opioids. So these are manifested as delirium, myoclonus, drowsiness, pinpoint pupil, etc. So if the patient has these symptoms, then we have to maybe skip 1 or 2 doses and then restart the morphine at a lower dose. And this is what some of you were talking by giving 1.5 milligram of morphine. And how common it is of in respiratory depression. Any of you have seen opioid producing respiratory depression when you use it for treating chronic pain? Okay, this is actually very rare, and you can see this is a systematic review which came in 2003, and it says that the patients usually takes their medications by mouth, that is through oral route, and the dose is gradually increased, which ensures that respiratory depression is unusual. Okay, so respiratory depression is very unusual. I have not seen a single patient with respiratory depression during the last 20 years of my career in palliative care. And not only with the oral morphine, but also with the injectable morphine or fentanyl. And they continues to say that when respiratory compromise occur, you should see whether the patient has a pneumonia or pulmonary embolism or cardiomyopathy or co-administration of another sedating medication such as benzodiazepine. So when you give morphine, as we talked, the chance of producing respiratory depression is very unusual. So this is another problem which many of us are aware of or feared of. Opioids causing addiction. How common it is. So these are the research findings which says substance abuse as a result of medical use is low. And there is a confusion between physical dependence and psychological dependence, where psychological dependence is known as addiction. Okay. So what is psychological dependence or addiction? Anybody? Okay, for you to understand it very simply, I will give you an example. How many of you takes coffee in the morning? Many of you probably. So suppose one day, if you do not get coffee in the morning, how your body will react to it? What would be the reaction of your body? Sorry? Rest. What else? What else? You have not. Okay, headache. Yeah. Restlessness, headache, yawning, not feeling good, irritable. Okay. So does this mean you are addicted to coffee? Anybody? Yes. Dr. Kanya says yes. That's a sign of addiction. Yeah. So what you have to understand is you have these problems: headache, irritability, yawning, etc. But this is because you have been giving coffee to your body for the last so many years, and you are suddenly stopping coffee, and your body is reacting to it, which is known as withdrawal reaction, or it is because of physical dependence. Okay, it is due to physical dependence. But if you have psychological dependence, you will break into neighbor's house where coffee powder and sugar has been kept. Okay, and then you will make coffee. So if you do that, then you will have psychological dependence. But if you don't do that, you do not have psychological dependence, you have only physical dependence. So this is not this can happen in case of opioids. Whenever you give opioids long term, when you suddenly stop, it will manifest as physical dependence. That doesn't mean that the patient has psychological dependence. So whenever you reduce or if the patient is on long-term opioids, you should not abruptly stop morphine or any other opioids. You should gradually taper the dose and then only stop. Okay. And there is a definition given by American Academy of Pain Medicine and American Society for Addiction Medicine in 2001, which they describe addiction as a primary chronic neurobiological disease. So see, addiction is described as a disease with genetic, psychosocial, and environmental factors influencing its development and manifestation. So suppose one of you have a genetic predisposition to addiction, and your psychosocial and environmental factors are favorable, like you are working in an operation theater where opioids are freely available, and one of your friend is misusing this. So psychosocial and environmental factors become favorable, and you have a gene for addiction. So in such instances, then there is a chance that you may get addicted to it. Okay, and thus addiction is manifested by impaired control over drug use and compulsive use. So you have broken into the neighbor's house. So you will do anything to get it. And you know that it is not good for your body, but even knowing this, you will continue to use it. And suppose you are giving morphine to a patient and you suspect that this patient is having addiction. The patient will be continuously coming to you for getting morphine. You have prescribed morphine for 1 month, but the patient comes in 1 week and says, I have finished morphine. I am taking 20 milligram, but you have prescribed 5 milligram. And so they will be continuously increasing the dose. And they may come and tell you, I lost morphine while my journey in the bus, or it got destroyed in the rain. So these are some explanations that they will give. Okay. I just want to tell you that according to NDPS Act, when you prescribe essential narcotic drugs, there should be, you should follow some principles. According to that, you should write the patient's name, age, and address. There should be date. You should write the name of the essential narcotic drug in capital letters, and what is the strength you are giving, and how many days you are giving, and how many numbers of essential narcotic drug you are giving. So all these are necessary along with your signature, name, medical council registration number, and address. Okay. So now we'll move on to comparative price of opioids. You can see that here morphine 5 milligram 4 hourly. So totally the patient would be taking 30 milligram, which would cost about 3 rupees 50 paise per day. So the equipotent dose of 30 milligram of oral morphine, when you convert it into tramadol, that would be 300 milligram. So if you give tramadol, then the patient need to spend 24 to 50 rupees. But if you convert it into a fentanyl patch, then 250 to 400 rupees to 3 per 3 days. And if you prescribing buprenorphine patch for the same dose of morphine, 1,920 per pair. And if you prescribe methadone, then that would be about 4 rupees 50 paise. So you can see morphine and methadone cost wise it is almost comparable. But tramadol, fentanyl patch, or buprenorphine patch, they are more costly. So if you prescribe fentanyl patch or buprenorphine patch for the patient, and if they are very poor, they would not be able to afford it. So please keep it in mind. And it is a good practice to understand the cost of medication, especially in palliative care, and where we want the patient to have symptom. So with this, I would finish my presentation, and if you have any doubts, you can ask.
Thank you, Dr. Sunil. I was telling them because in the first, after introduction of pain itself, everyone had so many queries. So I did mention to them that it will be dealt in detail, and I think they will all vouch for what I said, hopefully, because most of these queries were asked. And someone asked, what is the preferred opioid in renal and liver failure? Yes, yeah, Dr. Yadav, I think. Like, so basically we have covered, and they've given a detailed information on how they can use. And then this cost is very important, and it is gold standard for pain relief morphine. So, and many of them who are in this group have told me that morphine is available in their centers. So something which was nice to know. So that may be helpful for them. There's something else also. Kindly explain about converting IV dose to oral morphine. IV dose, is it the IV trial dose you want to know?
Over to oral.
That is the IV trial dose. That is when patient comes into, is that what is the query?
Yes.
So that is what he mentioned, isn't it? Like exactly 1:1. And it is only in that short period. That first bit is done in the hospital. Morphine trial. Dr. Sunil, you yourself answer maybe. Because what? I think that is their query. Morphine trial is their query, I think. Whoever it is, there's a lot of disturbance. Can you just say what is that you would like to know? Is it Dr. Vasanta?
What was the query?
Converting morphine IV to oral. I think it is the morphine trial is what is their doubt.
Yeah.
Is that right?
Okay. Starting was 1.5 milligram timing, same for so the opioid administration or intravenous morphine trial. It's the interval between two doses is 10 minutes. That is not hard and fast rule, but as a general principle, it would be go to wait for 10 minutes. But the peak action of intravenous morphine may take some more time, maybe 15 minutes or various literature says various times. But at least you have to wait for 10 minutes. And regarding why 1:1 conversion, that is what I think was asked. So then if you give morphine for a patient, if there should be a minimum blood level of morphine in the blood to give sustained pain relief. So for getting this minimum blood level, morphine will take about 24 hours to have this sustained blood level of morphine. So if you you are giving intravenous morphine trial for over 1 hour, so it is not over 24 hours. So for 1 hour, you are giving 3 or maximum 6 doses of morphine. So there will not be a sustained blood level. So that's why the 1:1 conversion is taken in a patient who is given intravenous morphine trial. But suppose if a patient is in hospital and he is on continuous intravenous infusion for the last 24 hours, then when you convert that patient to oral morphine, then you can multiply it by 2. Suppose the patient is on 10 milligram of continuous intravenous morphine infusion for the last 24 hours. Then you can convert it into 30 milligram of oral morphine. And there is no maximum dose of oral morphine for a patient. The dose which is prepared for the patient for pain relief is the maximum dose for that patient. I have seen patients who are taking even 1 milligram of oral morphine. Those who is on hemodialysis, and they have very good pain relief. Personally, I had a patient who is on 450 milligram of morphine 4 hourly. But I know another one of my colleagues' patient who is on 650 milligram of oral morphine 4 hourly. And in literature, if you look at, there are patients who are taking thousands of milligrams of morphine. So there is no maximum permissible dose.
Thank you, sir.
And why not bulk forming laxative? So there are many mechanisms by which morphine or opioids produces constipation. Some of the mechanism is, firstly, it will reduce the forward peristalsis, and it will also increase the absorption of water from the intestine. Then it will increase the sphincter tone. So when you give a bulk forming laxative, what happens? There is no peristalsis. So if there is no peristalsis, then that is going to actually increase the constipation or decrease the peristalsis even. So that's why bulk forming laxatives are not preferred. It will actually increase the constipation. But when you use stimulant laxatives means these are laxatives as well as it will increase the peristalsis. So bifacodine, sen or sodium hyposulfate, they are laxatives by themselves, but will also increase the peristalsis. So that's why stimulant laxatives are the choice for treating opioid-induced constipation.
And for there's another question, 1.5 milligram. I think that is dilution, to favor dilution and the
Okay.
availability, and you give in small incremental doses to see the benefit. Will
Yeah.
that be happy for the answer? Because some places 10 milligram vial also is available.
Yeah, but then 1 milligram would be okay. 1 milligram every 10 minutes.
Is that
Well,
okay
also-
for, because that was also a query, start one, and or is that the same for all weight ranges?
Yes, yes.
Mm.
All weight ranges means to above 2.
If
That can be.
if a big patient.
Yeah, about 2 years.
Mm.
And naloxone is available in India. We have kept it in our stock, but we have never used it.
Ideally, it's better to have naloxone always when, like if, as the doctor said, you won't need it. If you can have it, if you're going to use IV, you can have naloxone also.
And there's a question about the preferred opioid and renal failure and liver failure. So, renal failure, the preferred opioid is methadone or fentanyl, even buprenorphine, but usually it is methadone. But if you look at the literature, they will give various picture. The first choice is buprenorphine, second choice is fentanyl, third choice is methadone. This is very inconsistent, but we can say that morphine is not the preferred choice, or codeine is not good medication, but methadone, fentanyl, or buprenorphine can be used. And if this is not available, then definitely you have to use morphine. So morphine has to be reduced. Morphine has to be used in a lower dose with the spacing is reduced. So instead of 4 hourly, as I told you, it might be 8 hourly, 12 hourly, or even once daily. And in liver failure also, methadone is not a preferred medication in liver failure. Maybe morphine can be used, and it is safe. But if there is severe liver failure, then maybe the dose of morphine can be reduced.
There's one more question. Do all old patients, do we have to check serum creatinine before prescribing morphine?
We usually don't do any investigations to prescribe morphine. And there is another question on buprenorphine patch. So buprenorphine patch is not usually used because one is that it is, as I told you, it is a partial agonist, and the other one is that it is available as 5 microgram as well as 10 microgram patch. And the 5 microgram patch is equivalent to 12 milligram of oral morphine per day, and 10 microgram patch is equal to 24 milligram of oral morphine per day. So why should you start a patient on buprenorphine when they are taking 12 milligram? Rather you go to another maybe tramadol or something, or even low dose morphine. because it is going to cost the patient.
More. And also about IV morphine continuous infusion. I was not sure what they're asking. Recommended dose of IV morphine continuous infusion.
Yeah.
What
So,
for?
so the continuous infusion, first of all, you have to see what is the dose that patient requires. So if the patient comes, first of all, you do an intravenous morphine titration and find out the dose what this patient requires. Suppose the patient got pain relief with 4.5 milligram of IV morphine, then you can multiply it with 4.5 milligram into maybe 6 and give it over 24 hours and see after 24 hours you decide the dose, because it will take 24 hours to get a stable blood level. Sometimes the dose which you are giving might be a little higher, or sometimes it may be little lower. If lower, the patient will complaining of pain in between, and you have to give as well dose. Then you have to calculate how much dose should be adjusted after 24 hours.
Even for the creatinine, no, that query, because we are giving low dose and you are observing the patient and seeing, so like you when you start morphine and all, you will be in touch with the patient, review as we say. First week or so, we will be in touch, and then you see the response. And so generally, for even elderly, 5 milligrams, something what we start, they are okay. And then you review, and then if there's any gross difference, you go and check. Routinely, that shouldn't stop you from giving pain relief.
So please understand that morphine is still considered as the gold standard for treating chronic pain all over the world. So fentanyl patch or buprenorphine patch, those all, as I told you earlier, you would be very familiar with fentanyl patch or buprenorphine patch, because the representatives would be coming to you with marketing this patch. Because the profit is more. Nobody will come to you asking to prescribe morphine tablet, because there is no profit.
Radha, you are muted. Dr. Radha, ma'am, you were muted.
Oh, okay. Sorry. I thought I unmuted myself. I was just asking, we have gone beyond time. So what are we doing with the case presentation is what I was about to ask. Hello?
Yes, ma'am. It is basically for you and Sunil sir to decide. And also the participants' opinions does matter. So
We can take it quickly.
Yes, we will do it. They can present and then we will do, because we've had a good discussion, and we'll go ahead, Shipre.
Dr. Siddesh?
Hello.
Yes, sir. So
Yeah, I'm audible. Hello.
yes, sir, you are audible.
Yes, please go ahead.
Yeah, hello, ma'am. Hello, everyone. Good evening. Myself, Dr. Siddesh Trambake, Medical Oncology Resident, Omega Hospital, Hyderabad. So today, next slide, please. Yeah. So today I'll be presenting case of 54-year-old male who had presented to our OPD 15 days back. Next slide, please. With complaints of headache, severe pain all over the body, abdominal distension, again, which was associated with abdominal pain, lower back pain with pain radiating to bilateral lower limbs, more so on the right side than the left, anorexia, and difficulty in passing stools. So he is a known diabetic and had presented to a general physician and later on to a hematologist 1 year back with lower backache. He was diagnosed after multiple investigations to be having multiple myeloma, ISS stage 3, and received palliative radiation to lumbar vertebrae, followed by 12 cycles of VCD chemotherapy along with zoledronic acid being the bisphosphonates here, and concluded his treatment in October 22. After his treatment, patient was in complete remission with his urine and serum electrophoresis being not suggestive of MPAND, while the plasma cells in the bone marrow were lesser than 5%. However, he was not affording any maintenance treatment or bone marrow transplantation. So after a DFI of 3 months in February 23, he developed abdominal distension, which was associated with alternating episodes of constipation and diarrhea. PET-CT was done, which showed a large intra-abdominal mass along with progression in the bone, which showed disseminated lytic lesions involving axial and appendicular skeleton. Abdominal mass biopsy was done, which was suggestive of multiple myeloma, and thus he was diagnosed to have a relapsed multiple myeloma. Thereafter, he received re-radiation to the lumbar vertebrae and intra-abdominal mass using conformal techniques of radiation delivery like IMRT. He was again not eligible for bone marrow transplantation in view of financial constraints and hence was planned for second-line chemotherapy. After which he received monthly carfilzomib, lenalidomide, dexa, and denosumab for 3 cycles. And a response assessment PET-CT was done in first week of June, which unfortunately again showed progressive disease with new lesions in the skull. So when he presented to us, he was complaining of severe headache, pain all over the body with a pain score, numerical pain score of 6/10, while he was on paracetamol and buprenorphine patch, along with colicky abdominal pain with a pain score of 4/10. So on inspection, he is a middle-aged guy, poorly nourished, almost cachexic, with and appeared depressed at the time of presentation. On palpation, per abdominal examination showed 10/10 centimeter hard fixed irregular mass in the right iliac fossa. Bony tenderness was elicited at dorsal and lumbar spine along with right hip. There were no neurological symptoms except for headache. Straight leg raising test and other specific tests to the back and leg pain could not be elicited due to severe pain. And all other parameters, including vital parameters like pulse, BP, and SpO2, are within normal limits. So at the time of presentation, he had some labs done already, which showed deranged RFTs with creat being 3.2, blood urea nitrogen being 63, and GFR of just 40. His electrolytes and LFTs were slightly deranged, and being a diabetic, his sugar control was mildly affected. He had USG ton, which showed right adnexal mass of 12/13 centimeter with right-sided hydroureter with hydronephrosis. The PET-CT, which I had gotten, showed multiple mets all over the body, which included skull bone. However, there were no intraparenchymal brain mets, along with mandible, multiple vertebrae, ribs, pelvic bone, and intertrochanteric region of right femur. As far as psychosocial aspects go, the patient appeared depressed, not much interested in living, had suicidal thoughts. He was working as a clerk in private bank, currently unemployed, married with 2 children, and had been a sole bread earner of his family. His wife had abandoned him along with children after his initial diagnosis and currently resides at her maternal place. He is being taken care of by his elder brother and a friend and is currently financially exhausted. He had 2 prescriptions along with him when he had come. One prescribed by the hemat-onco team, which included anti-diabetic medications related to his GI symptoms, along with laxatives, protein powders were prescribed, multivitamins, and alprazolam as well. As far as pain management was concerned, he was having Dolo 650 tablet, that's paracetamol tablet, and Bular patch, while he was advised for whole brain radiation and neurology review. While the other prescription was given by the palliative care unit, which stated morphine tablet 5 mg QID, along with Ultracet, that is paracetamol and tramadol combination, Dolo, gabapentin, along with laxatives. Next slide, please. So the main concern for this patient was that he was resigned to his fate, had accepted that he did not have long to live. Abandonment by the family was the main concern, along with financial burden and insecurity. One of the main concerns was future of his kids, and he was not willing to take any further treatment as he had lost faith in the treatment itself after the relapse. And for us, it was how to increase his compliance, how to go for the next step of management while working on his attitude. So to summarize, a 54-year-old diabetic male suffering from relapsed multiple myeloma with deranged kidney function, intra-abdominal mass, multiple bone mets, had presented with headache, constipation, severe pain all over the body, lower backache with radiculopathy, anorexia, and vomiting, is depressed and apathetic towards his treatment, owing to lack of his family support and disease progression. So the points I want to discuss here would be would financial affordability have rescued his this patient of his fate? What if he was, financially stable and would have afforded consolidation treatment right at the first diagnosis? Secondly, in case of compromised RFTs, what is the best analgesic option available in the absence of methadone availability? Then family support, how important it is as far as patient support programs are concerned, and why is palliative treatment considered as a last resort most of the times, and how can we give hope and increase patient compliance, or should we just let him pass away in peace in this particular scenario, and that would be the ultimate patient's prescription. Thank you.
Yeah, thank you, Dr. Sudesh. We'll keep this open to the team for discussion. Your first question is a very tricky question. Financial affordability. I don't know who will have the courage to answer that question. Sripriya, maybe we can come out of the screen so that everyone participates. Yes, like people can bring up your thoughts and ideas to the main concerns what Dr. Siddesh has raised. And then we'll go into the... Okay, if no one is, or is there something in the chat? What advice to give for patients about maintenance of patches? Oh, okay. Is fentanyl the drug of choice here? Is it for this patient you're telling fentanyl? When after this lecture, when this patient is already financially burdened, will fentanyl be the right choice for him? Whoever had, wait, let me see. Would you want to change your, is it because of the renal thing in mind? You can give appropriate dose. Timing can be. See, and also his pain score was 4/10. Is that, Dr. Siddesh? That's what you said, right?
Yes,
to start
yes,
4/10, 5/10. And with the morphine, was he, first thing, many times, is he taking that morphine regularly? Many times you'll have to check that the morphine might have been obtained and kept there, not used. So as physicians, we have a good amount of role to play. We have to make sure that was your patient taking the medications with his morale and mood and everything? Was he taking the medication?
He wasn't much motivated towards taking further treatment, so I doubt his compliance actually.
And then as someone has mentioned, Ultracet and morphine are generally not given together. And buprenorphine can be used, per oral buprenorphine. Is that available everywhere? So D-range RFT and buprenorphine is costly and methadone unavailability. So with all that, maybe they thought of fentanyl patch. I think that's what they have replied for. And next question, with D-range RFTs, buprenorphine can be used. Are you asking that with the D-range RFTs using buprenorphine, is that a better choice? Dr. Sunil, if you want, if you could go ahead and answer whatever you would like to, please.
First of all, I would like to thank Dr. Sudesh for this patient story, which he presented very well, and he has brought out many important points. Regarding the treatment and the financial or affordability, I would like to ask Sudesh that if he was financially well, do you think he would get good treatment and he would be cured?
The chances were low, sir, but at
Okay.
least he would have been satisfied. Now he feels that maybe if he had money, he wouldn't have landed in this situation. So that's more of psychological. I think.
Okay, I think that's something which we have to communicate to him, because even though I do not have time, I have to attend another meeting. But I want to give you for the story which I have experienced. We had a patient with advanced malignancy, and the oncologist told at this stage nothing can be done, but the patient was asking for something. So what he told was there is some treatment which will cost 5 lakh per cycle. If you can afford that, then we will give that. Not exactly 5 lakh, but that's what he conveyed to him. So oncologist did it because he knows that it is with a good intention only he did, but that actually caused or problem with the patient, because he thought that because I am unable to afford, I can't get that chemotherapy. So this is the another aspect of it. So if we cannot, if we do not think that this will not good any for will not do any good for the patient, better to talk to him openly and tell him, okay, this is what we believe. That's it. And you will know more about this.
Communication.
Yeah, communication. But as somebody told, morphine and Altracet is not given together because one is a opioid, weak opioid, the other is the strong opioid. So if you need the dose of morphine need to be increased. And as the renal, we told that in renal failure, morphine is not a good medication. Methadone, buprenorphine, phenyl, maybe the good choice. But here, I would not consider buprenorphine patch or phenyl patch, and you do not have methadone. So I would go with morphine itself, and I would closely monitor the patient. So that's what I'm going to do for this patient, because we are doing this when methadone was available on since 2018 or 19, and till then all of mostly the Indian palliative care physicians were managing patients with morphine, most of them, and then this even though it's available, most of them would use morphine in a titrated fashion. And I think another important thing, the patient is depressed and there is nobody to talk to him. So if that patient was with our unit, what we would have done was we would ask some of the volunteers to visit him frequently and talk to him, so that it will give at least some relief for the patient. So we have to think in that terms. Somebody from our team should make a good relationship with him, and basically we should provide a companionship for the patient, because his wife and children has left him. So that itself is a psychological, severe psychological stress. So the volunteer or somebody else would not be a substitute for the wife and children, but still the volunteers, psychologists, and etc. Or our palliative care team do have a role in those patients with psychosocial problems. And there was one other point which I wanted to tell you. So Priya, can you show me the slide again?
Yes, sir. Remember.
Yeah. Why palliative care treatment is considered as a last resort? Somebody has already answered that. So awareness regarding palliative care is very low, and many of the people, including the professionals, think that palliative care is the end of life treatment. So that problem or this issue of a misconception has to be changed. Otherwise, this is going to be considered as the last resort of therapy. And patient's prescription. So I would gabapentin is given only 200 milligram, and one of the things that even gabapentin is excreted in the renal route. So in patients with reduced kidney function, they have to reduce the dose. But I think 100 milligram daily would not be enough, and I would actually give him amitriptyline if he is suffering from neuropathic pain. I couldn't see whether there is a neuropathic pain or respiratory pain. Some of the drugs which are safe in renal failure is paracetamol. NSAIDs we would not, as far as possible, avoid it because it can again reduce the renal function. Then adjuvants, tricyclic antidepressants can be given. Duloxetine can be given, but if the eGFR is less than 30 ml per minute, then it is contraindicated. But amitriptyline, imipramine, all those can be given. Sodium valproate is another drug which we usually use in neuropathic pain, which can be used. Then regarding tramadol in the ESRD, that is end-stage renal disease, up to 100 milligram per day should be okay. But codeine is not usually used. Morphine, as I told you, we need to use because we do not have any other opioids which are easily available and not costly. Then methadone, I think, would have been a good choice, and if possible, we should get it because if you have a RMI status, a medical institution status, you can actually stock and dispense all the essential narcotic drugs, which includes morphine, fentanyl, methadone, then codeine, hydrocodone, oxycodone. But hydrocodone and oxycodone are not available in India. The other four opioids are available. Yeah. So that's what I.
Thank you. Thank you very much, sir.
Thank you, Dr. Sunil. That's what, it's a holistic approach. See, that's what you will know by the end of this whole sessions. That, see, here more of psychological, and first thing you have to tell him that, okay, because he got, he's not, you said that he's not convinced, no, because nothing else worked. But you can tell him that symptomatic relief you will give. So that's what is palliative care. And that's why we say in our first day of session, what we had, palliative care starts hand in hand. So the percentage may vary. So those are things which you're going to take from this whole program, that it should be a holistic approach, and you give assurance, tender loving care that you are good. The next thing is that for that only you need a team. A social worker or someone can be there, like a volunteer, what he said, social worker or volunteer, and then some psychological support, both for him and the wife separately. She may, once she knows actually, because they might not have known the prognosis and things, which you will know in great detail in your communication session. So all that, there are multiple things which have to be. And then today's main aim is pain relief, and then for which morphine can still be used at titrated doses. You find the correct dose, increase the duration, like frequency you're giving, check your use and ease, and do like that if required. And then clinically see the patient if he's comfortable. All that multiple factors are there. And then financial support and all, if you make some contact with NGOs and give that patient assurance that the children's education will be taken care of. See, that would have been the main issue many times. So then this pain relief also may be better off with your medications. So that's what, it's multifactorial. And as you go through with the sessions, everything will be appropriately covered. And always you use the pharmacology, what you know, to give the best to the patient, having the financial element also at the back of your mind. That is what is important. Okay, hope anything else is there in the chat. I'll just check. No, nothing new is there. Hope everyone are happy with it. And then in that case, I will hand it over to you, Sri Priya, then.
Thank you, Dr. Sunil Kumar. I do definitely know that your day has not ended yet. Even though you had a very busy schedule, still you have your day left. And thank you so much for joining us at this time and providing a much valuable information to all our participants. Thank you so much. And thank you everyone for making the session so much interactive and informative. We do expect such participation in all sessions. And with the promise that we'll meet again with another topic on pain in the next session, which is on, actually we don't have session on 28th. On to it, we will definitely update that also in the group. So our next session would be on 1st of July only, on Friday. We don't have a session on Wednesday. So reminding that this is Sri Priya along with Dr. Sunil Kumar and Dr. Ratha Venkatesh signing off from the Tipsico Hub. See you in the next session. Till then, everyone take care. Bye-bye.
Thank you, Dr. Sunil. Thank you, everyone.